Congress will include varieties of important topics related to bariatric surgery in terms of standard of care, long-term outcome, endobariatric, and also pharmacotherapy and dietitians and nutrition's issues related to bariatric surgery. We know this society is comprehensive related to surgical issues, but also to our colleagues in the allied health, nutritionists and physicians, endocrinologists, and others. So without delay, thank you for everybody who participated in this meeting, for the international speakers from around the globe. I know some of them were going to the airport and really sharing with us this meeting. And even before going to the airport, they are giving the talk. So thank you so much. I know it was short notice, but I appreciate your contribution. Now, it's my pleasure to introduce our president, Dr. Adnan Mufti, who really has led this society for another stage of development, another achievement in the last 4 years, and looking forward for more work from his side to give the presidential welcoming message of this Congress. Dr. Adnan. Yes, we'll have the go.
Okay.
Yes.
I can share my screen now.
Yes.
Thank you. Thank you very much. Prof. Ayed, thank you very much for taking charge of organization and with your team from the members and your admin people who organized this sitting. It's my pleasure and honor as a chairman of the executive board of the Sasmbs and the members of this society to welcome everybody who's contributing to this Congress. To start with our executive board, who has worked with everybody to make this a success, either it is even if it is on a virtual mode. This is our 5th annual Congress to be organized during the term of this executive board, which was started in 2017. And I am very grateful for our legendary expert from international ground who agreed and participating in this Congress from all over the world. We are very grateful for their contribution. Our national contributors also are welcome. They give us rich input and contribution to this Congress, and I am very grateful for their part as a panelist, as a chairman of session, and as speakers in this session. I can't go over their names. There are many of them, but we are very grateful for them, and they represent all the specialties and all the modalities of the practice in the management of obesity and its prevention. Also, I'd like to extend our thanks and gratefulness for our sponsors who have contributed generously to support the organization of this Congress. Thank you very much for everybody, and I will leave now the floor for the moderators and chairmen of the first session to carry on with the business of this Congress.
Thank you so much, Dr. Professor Ayat, and thank you to Professor Adnan. And good evening, ladies and gentlemen. I welcome you all to our fifth annual Congress, and the session will be started today with the title of Standard of Care. Is it a legal term or a medical term? It has a lot of meaning as long it's been used in a different sector in our life. But in our medical practice, the standard of care usually means the degree of care and skill of the average healthcare provider who practice in the provider specialty. And as part of our mission in the Sasmbs to upscale the standard of care, we have today with me a very distinguished panelist and eminent speaker who will give us a great insight about the standard of care in bariatric surgery. Let me first to welcome our panelists with a brief introduction. Our president, Professor Adnan Mufti. Uh, I cannot speak much more about his contribution and his legendary background and all what he have done to our society and the bariatric surgery. He is almost the father of bariatric surgery. He is a teacher. He is the big brother for all of our colleagues in the society. Our next, my colleague and also our colleague, Dr. Abdullah Zahrani, currently assigned as the consultant of upper GI and bariatric surgeon, the head of upper GI and bariatric surgery department in Prince Sultan Medical City in Riyadh. He is also one of the eminent and a member of several national and international surgical society. He is a recognized and examiner in the Saudi board since 2009 and the vice chairman of Surgery Council in Saudi Council. Dr. Wael Gattan, he is the head of Department of Surgery, Director of Academic and Student Affairs, Associate Professor of Surgery, College of Medicine, Al Faisal University, Riyadh. Dr. Hanan Al Ghamdi, Professor Associate Hepatobiliary and Bariatric Surgeon, Imam Abdul Rahman bin Faisal University. And our guest who had more than 25 years of bariatric and metabolic surgery experience, Dr. Shower, Professor of Metabolic Surgery and the Director of Bariatric and Metabolic Intuitive at Bennington Biomedical Research Institute in Louisiana State University. Before coming to Louisiana, Dr. Shower, he was the professor of surgery at the Cleveland Clinic. He was our mentor there at the Lerner College of Medicine, and he is the past president of the American Society for Metabolic and Bariatric Surgery. He is also the former chair and founder for Obesity Week and co-chair of Diabetes Surgery Summit. Dr. Shower, clinical interest, including obesity, diabetes, and metabolic syndrome. He has performed more than 8,000 operations for those conditions, and his research interests include the pathophysiology of obesity and type 2 diabetes, and the outcome of metabolic surgery. Dr. Shower authored more than 350 scientific papers, 60 textbook chapters, and there is a textbook related to that and gastrointestinal surgery with more than 20,000 citations. He is also the principal investigator for the Sasmbs trial that it has been published and announced in New England Journal of Medicine with more than 3,500 citations. Without further and more, I can speak the whole night for you, Dr. Shower. The floor is yours, sir, to start.
Well, thank you very much, Dr. Bataya, for that very generous introduction. And I'm also very proud of your training at the Cleveland Clinic. And I appreciate so much that you have brought that training back to Saudi Arabia and have been contributing much to the growth and development of bariatric surgery in Saudi Arabia. I also want to acknowledge my friends and colleagues, Professor Al-Qahtani, and also the president, Professor Mufti. I really appreciate the invitation to speak at the Saudi Arabia Metabolic and Bariatric Surgery Conference. I visited Saudi Arabia many times, and I've always enjoyed interaction with the bariatric surgeons in Saudi Arabia. So I've been asked to talk today about selection criteria for bariatric and metabolic surgery. And let me bring up my slides here. There we go. And I hope that my audio is okay. I'm assuming my audio is good. So
Great.
Very good. Thank you. So as Dr. Bataille had mentioned, I spent the last 15 years of my career at the Cleveland Clinic, but have taken on a very new, very exciting opportunity at the Pennington Biomedical Research Center in Baton Rouge, Louisiana. And I'm delighted to surround myself with more than 250 scientists who are devoted to obesity and diabetes research. So we hope to make a really big impact in the near future. I hope if you come to the United States, please come and visit us in Baton Rouge, Louisiana. These are my disclosures. I don't believe there's any particular conflict with my presentation today. Now, I do want to alert the members today to a new exciting webinar that I host once a month. It's called Metabolic Surgery Grand Rounds, and it's the first Thursday of each month. And on July 1st, we have an exciting program where 3 of the individuals here will be presenting some recent publications of metabolic surgery and how it can reduce cardiovascular events or MACE events. So please join us if you can. It's free, and you can register at our website, which is pbgrandrounds.org. And we have a panelist of renowned investigators who will challenge the speakers on their presentations. Now, let's get back to selection criteria. Selection criteria for bariatric surgery actually dates back to the 1990s, when the National Institutes of Health in the United States put forth the first document that recommended criteria for bariatric surgery. And since then, a variety of organizations have endorsed bariatric surgery with a variety of criteria. I will acknowledge this, this document, Guidelines for the Management of Obesity, that was published in 2014 and is probably one of the most widely endorsed documents on criteria for bariatric surgery. It's been endorsed by more than 30 to 40 professional societies. And the actual indications for surgery are very similar to what they were in 1990. Essentially, these guidelines are based on body mass index, not necessarily comorbid conditions, but a BMI of 40 or greater, or a BMI of 35 or greater with some type of obesity-related comorbidity. The patient should, of course, be motivated and desire to lose weight, and the patient should have tried less invasive approaches such as diet, exercise, and or medications prior to embarking on surgery. So for many years, these have been the global or international standards for criteria for bariatric surgery. Now, over the last 5 to 8 years since these guidelines, a variety of really outstanding scientific studies have accumulated that have begun to alter these indications to allow for more broader indications and specifically lower body mass index. For example, we now have 12 randomized controlled trials comparing bariatric surgery to medical treatment for type 2 diabetes. And you can see our Stampede trial was one of the first, but there have been a number that have essentially corroborated these results, which indicate that metabolic surgery is actually superior to medical treatment at improving overall glycemic control. And essentially all of these studies, I showed that with a p-value that was statistically significant, favoring metabolic surgery. In addition to these small randomized trials, the other new information we have are information from very large retrospective observational studies. And here's an example of a study published from our group at the Cleveland Clinic, published in JAMA in September 2019. And this study, which compared over 2,000 patients who had metabolic surgery with more than 10,000 control patients, this study concluded that metabolic surgery resulted in a 41% reduction in mortality, 62% reduction in heart failure, 31% reduction in coronary artery disease, 33% reduction in stroke, 60% reduction in kidney nephropathy, and actual reduction in atrial fibrillation as well. And there are now more than 30 observational studies that show very similar findings. Most recently, just 1 month ago in Lancet, a very large meta-analysis by a number of noted investigators, including David Cummings, who I understand is one of the speakers at this session today. And this study is a very powerful, large analysis of more than 174,000 patients, showing that metabolic surgery reduces significantly mortality associated with obesity and type 2 diabetes. And this is very profound information. So it's information like this that has allowed us to alter the new guidelines. Many of you remember back in 2015, the Diabetes Surgery Summit met in London that included a variety of experts in obesity and diabetes around the world and delivered a consensus statement on new criteria for metabolic surgery. And this consensus statement was published in 2016 in Diabetes Care. And this has been a very well documented statement. And let me summarize that to you right now. The statement was published in that edition of June 2016 and basically states that patients with obesity and type 2 diabetes should have metabolic surgery regardless of how well their diabetes is controlled. Patients with a BMI of 35 or greater should have metabolic surgery, especially those who are not in good glycemic control. And for the first time in history, we have international consensus that metabolic surgery should be considered even for patients with a BMI as low as 30 if they are not well controlled with medications. And this document went one step further to lower the BMI to 27.5, especially for people of certain ethnic groups such as Asia, India, the Far East, who are more metabolically prone to complications of diabetes, that the BMI could be lowered to 27.5. Now, many organizations have adopted these guidelines, including the American Diabetes Association. And here are the guidelines from this year, 2021. And they essentially are exactly the same as the DSS guidelines first published back in 2016. Now, just a couple years ago, just prior to the COVID pandemic, the World Congress of Interventional Therapies for Type 2 Diabetes met again to understand better not only the guidelines, but how are the guidelines actually being utilized in practice across the globe? Are they being implemented into clinical practice? And the organizers you're very familiar with, Francesca Rubino, Will Cephalou, who at the time was the executive director of the American Diabetes Association, David Cummings, Lee Kaplan, and myself. And the issue is, what is the utilization of metabolic surgery? And based on a pre-conference survey, this graph shows you how well metabolic surgery is utilized across the globe based on the country. And you can see that here Kuwait had the highest utilization, but a very disappointing 3%, meaning only 3% of patients who were eligible are actually getting the surgery. Now, Saudi Arabia is a little bit better. I mean, is not quite as good, 1.24%. And the United States is less than 1%. And many countries in the world are less than 0.5%. So it suggests that despite these guidelines, the utilization really is not nearly as good as what it should be. Now, one of the goals of that conference in 2019 was to identify what were the causes. Why is there not greater adoption? Is it safety? Is it education, patient awareness? Is it the cost of surgery? Is it insurance coverage or something else? And they identified that stigma or prejudice toward people who have obesity was one of the major factors. And since this conference, I want to share with you a major consensus statement that was published last year in Nature Medicine. This is a consensus statement that has been endorsed by many organizations all over the globe about the underpinnings of why treatment for obesity is very underutilized. And I don't have time today to go into detail, but I encourage you to read this consensus statement. But the executive summary states that obesity stigma or ignorance about the understanding of this disease and the prejudice toward people with obesity is a major factor in why more patients are not getting effective therapy. So in conclusion, although our guidelines have progressed over the past decade, metabolic surgery is underutilized in every country in the world. And we have to do better in terms of education, awareness, addressing access to coverage, and most importantly, this issue of obesity stigma. We have to address these so that our patients can get better access to scientifically proven evidence-based treatment for obesity and diabetes. So I think I'll end right there. And if there's any time for questions, I'll be happy to address any questions. And I do want to thank the organizers for inviting me to this very important conference in Saudi Arabia. Thank you.
Unmute, Isam. Unmute.
Thank you, Professor Shower. We will keep the discussion to the end of the session, and we will go through our second speaker. Our second speaker is Dr. Sultan Al-Dimyat. Dr. Sultan Al-Dimyat, he is the founder of the Sasmbs, actually, who established the society in the early beginning. He is one of the leaders and the teacher of bariatric and laparoscopic and advanced minimal invasive surgery in Saudi Arabia. His contribution is huge, especially in conducting too many workshops. Until today, he is still the teacher of bariatric surgery, and now he is the director of Badana Center. Dr. Sultan will talk about the update in the pre-operative workup. Dr. Sultan, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. It's my honor and pleasure to be here with you today in our annual meeting, Sasmbs meeting. Let me just share with you. Okay. Okay. The purpose of this talk today, it will be a review of the preoperative evaluation of patients undergoing bariatric surgery. It's an overview of the general concept, and then we will focus on more common comorbid conditions.
The slide is not moving?
Not moving, no. Okay.
Yes, okay.
So the preoperative workup and preparation of the patient usually is started by patient assessment, and this should include obesity-focused history. The history is very important and should be taken in details from the initial contact with the patient. This should include weight loss attempt, cardiometabolic symptoms, or other obesity-related disease, GERD, snoring, symptoms suggestive of obstructive sleep apnea, and symptoms of psychiatric illness. These are very important information and can give you a hint about the comorbid conditions that need to be addressed later on in the multidisciplinary work. Smoking and alcohol intake is very important, and this is the time to tell our patients that they should stop smoking because, as we know, preoperative smoking cessation can minimize the postoperative complications. And usually we ask them to do that 3 to 6 months before surgery. And if they can maintain it for life, this is the good thing. The current medications note is also very important because some of the medications we need to change, titrate, or even stop prior to surgery. The assessment continue by measuring the body mass index, and then waist circumference also is important, and then to be followed with discussion with the patients about the surgical options, and usually whether the procedure is related to weight loss procedure or metabolic procedure or procedure treating GERD following bariatric surgery or revisional bariatric procedure. Okay. The multidisciplinary approach here, it's very important in the pre-op workup, and for the sake of the time, I'll just focus on the common conditions that you are encountering in obese patients. Cardiology is the evaluation of obese patients is very important because obesity has a negative effect on cardiovascular health. The presence of obesity increases the risk of coronary artery disease, heart failure, cardiomyopathy, hypertension. All of these condition, disease, if not optimized, can lead to poor surgical outcome. And the risk, usually the risk of the preoperative complication depends on the condition of the patients before surgery. And they classified our colleague to minor risk factors, intermediate risk factors, as you can see here, and they have the high risk factors or major risk factors. The initial assessment usually by our colleague, the cardiologist, they do what they call the functional capacity. And the information they obtain from the functional capacity is an important step in operative cardiac risk assessment. And they usually they measure it in metabolic equivalent, or what they call METs. So 1 MET is equivalent to the basal metabolic rate. And the exercise, as you can see, the exercise testing provide an objective assessment of functional capacity. So they grade it from 1 to 2 to 3, 4. Usually less than 4 is poor functional capacity. Now, the general evaluation of patients usually started with the 12-lead ECG, and almost recommended for every patient. There is according to different guidelines. And further evaluation followed by stress testing of usually the stress testing indicated when there is a probability of coronary disease based on the ECG finding. Echocardiogram can be helpful in case the patient cannot tolerate the stress testing. They have also the nuclear cardiac imaging, and we have limitation here in morbidly obese patients because of obesity. It's usually the problem with obese more than body mass index of 30, which is usually this is specific to our populations. There is increased evidence that cardiac CT angio very helpful tool in evaluating the coronary fizzle in patient unable to tolerate the exercise prior to invasive procedure. The procedure of choice, of course, will be the cardiac cath here, and can be it's diagnostic and therapeutic. The problem with the cardiac cath, it might delay the procedure in case of a placement of stent and initiation of the dual antiplatelets therapy. This is the guidelines. This is very important guidelines on non-cardiac surgery cardiovascular assessment. It's from the European Society of Cardiology and European Society of Anesthesiology. This is their risk estimate according to the type of the surgery, and they classify it into low risk, less than 1%, intermediate risk is from 1 to 5%, and high risk more than 5%. The risk here is the 30-day risk of cardiovascular death or MI, and it's related to the procedure itself. As you can see, bariatric is not listed here, but I think it's somewhere between 1 and 5. Probably it's intermediate risk as a procedure. This is the level of evidence they have it. You're all aware of that. Just to remind you, level A, level of evidence A, it's data derived from multiple randomized clinical trial or meta-analysis. Level B, it's data derived from single randomized. And level C, consensus opinion or small studies. This is the classes of recommendations. Class 1, 2, 3, 4, it's recommended, indicated, should be considered, and maybe considered. Here is the recommendation for routine perioperative ECG. As you can see, pre-op ECG is recommended for patients who are having risk factor and schedule for intermediate or high risk surgery. It's maybe considered in patients who have low risk surgery. It's considered for patients who have risk factor above age of 65, and it's not done routinely for patients who have no risk factor and are scheduled for low risk surgery. The recommendation for echogram, this is their recommendation on wrist echocardiogram, may be considered in patients undergoing high risk surgery. Routine echo is not recommended in patients undergoing intermediate or low risk surgery. The recommendation for stress testing, as you can see here, it's recommended before high risk surgery. It's may be considered before high or intermediate risk. It's not recommended before low risk surgery, regardless of patient clinical risk. Now for the hypertension, hypertension is found in up to 25% of our patients. It's an independent risk factor, and treatment usually with the beta blockers decrease the risk of myocardial infarction. And the beta blocker should be initiated several weeks before the surgery, and the dose titrated to achieve a resting heartbeat of 50 to 60 beat per minute. Abrupt discontinuation is dangerous, and since most of our procedure is elective, that we can delay the procedure until we have a good control of the blood pressure. And this is their recommendation in that study. The patients with the new diagnosis hypertension, it's recommended that patients with the new diagnosis hypertension to have a preoperative screening for end organ damage and cardiovascular risk factor. Large perioperative fluctuation procedure should be avoided. Clinician may consider not deferring patients with grade 1 or 2 hypertension. This is again the recommendation beta blocker, we just mentioned it. And regarding the pulmonary evaluation, it's one of them, probably the second important condition usually we see in morbid obese patients, because obesity is also a risk factor for airway disease. Or we have a problem with the mechanical restriction. We have increased deposition of adipose tissue that can reduce the chest wall expansion and decrease the oropharyngeal patency. The reduction in they call it the expiration respiratory volume. This is one of the commonest things that we usually see following, we see in obese patients. Obstructive sleep apnea is a condition in which the upper airway periodically becomes narrowed or obstructed during sleep, and usually resulted in reduction or even cessation of breathing during sleep. Most of the patients, they have the diagnosis of obstructive sleep apnea during the preoperative workup. In addition to that, we have the condition, they call it obesity hypoventilation syndrome. This is usually happening to super obese patients. They have pulmonary derangement while awake. And this is also make it more difficult. Now, regarding the gastrointestinal assessment prior to surgery, this is one of the important topic, and it's very important issue, especially the gastroesophageal reflux disease following bariatric surgery. That's why most of the society and guidelines now, they recommend preoperative gastroscopy, because we can get up to 90% abnormality, and 62% of these abnormality usually significant finding. This guidelines from ASMBS, this has been published in 2015. They have searched the midline and the PubMed the databases for publications between 1980s and 2013, and they found in this review that endoscopic finding that it changed the surgical approach is ranging from 1 to 9% of the patients only. And the presence of hiatal hernia with endoscopic finding of reflux esophagitis represent a relative, not absolute contraindication to sleeve. And because this is because of the risk of development of de novo GERD-like symptoms. And the surgeon advocate hiatal hernia reduction and chronal repair for every patient having this problem. Yeah.
2 minutes.
Okay. And this is the role of upper, this is very important. This is very important study from our colleague, Dr. Ali Khammas in Rashid Hospital in Dubai. They have studied 1,278 patients who had routine endoscopy prior to surgery, and they classified into 3 groups. Group 0 with no finding, normal endoscopy. It's about less than 11% of the patients. Group 1 with simple, they call it non-significant findings, simple gastritis, simple duodenitis, and other group with significant findings, including Barrett's esophagus. Interesting that the majority are in group 2. And here you can see it. And this is their study compared to other study, 10%, 10.6 normal endoscopy, and 63% with significant abnormality. So they recommend doing routine preoperative endoscopy. Now for the very important issue, which is the venous thrombosis, VTE prophylaxis. I have reviewed this the guidelines from the American Society of Hematology. It's a very long one, maybe 60 pages. Nothing new, just maybe new definition about short-term prophylaxis, extended course prophylaxis, and there was no big difference between low molecular weight heparin or unfractionated heparin. They just recommend combining mechanical and chemical method to treat this problem. Aspirin, it's very important, and one of the hot topics. Usually we discuss it with our colleague, the cardiologist. And this is study very important. They randomized 1,000 patients in 2 groups, one with aspirin and the other placebo, and they have found in their study that aspirin will not lead to increase cardiac events following surgery for the patients. They did not take the aspirin, and they recommend giving only a small dose of aspirin for high-risk patients based on individual managements. Nutritional assessment is also very important prior to surgery, because it can show the patient nutritional status and also the commitment of the patients for the post-op protocol. Psychological assessment is important. For the sake of the time, I think I will stop here. Thank you very much.
Thank you very much, Dr. Sultan. I know the topic is a little bit long and it might need more time with that, but maybe we'll keep the next of the remaining points that you just mentioned in the discussion. Our next speaker is Dr. Michel Gagnier, who obtained at the age of 22 his MD in 1982, and he did his surgical training in McGill. Professor Gagner, he was appointed to Professor of Surgery and Director of MIS Center in Mount Sinai in New York from 1998 to 2003. He then joined the Weill Cornell in New York as a Professor of Surgery and Chief of Laparoscopic Bariatric Surgery. He was there until recently a Chair of Surgery in Mount Sinai in Miami, and he is currently a Professor at FIU and a Senior Consultant at Hospital at Deucewear in Montreal in 2014. He found non-profit organization of World Without Obesity. Dr. Gagner, he is known the contribution of his MIS in particular as the first description of many laparoscopic procedure and the most common pioneer of regard the founder of sleeve gastrectomy in 2000. And he held the position of more than 35 society. He served as an editorial board, and his contribution in the publication and articles, book chapters. He is visiting professor and operating in 60 institutions over 48 countries. Dr. Michel Gagnier, we're delighted and honored to have you today and to talk about the imminent, do we have the perfect sleeve?
Thank you very much. I hope you can hear me.
Yes, we can.
Okay, so I was told I have to thank you very much for the invitation. It's an honor to speak at the Saudi Society of Bariatric Metabolic Surgery. Let me go and share my screen. So I've entitled this How to Avoid and What to Do with an Imperfect Sleeve. First, you can see my screen. Thank you.
Yes.
I want to thank my friend editors for this book, which is entitled The Perfect Sleeve Gastrectomy. I guess that's why you decided to ask me to speak on this topic. It is by Springer and has all the chapters related to sleeve problems, complication, as well as revision. So how common are revision? A good idea to know if it is perfect, it is imperfect, because if we look at the 10 years sleeve gastrectomy in France, out of 225,000 sleeves, you can see that revision is increasing over time, reaching close to 12% at 11 years. So as you go by time, it increases, and especially if the patient had a previous bending, so bending to sleeve, they were more likely to need a revision because probably the sleeve was imperfect at the time of revision of a band. Factors that have been associated with revision have been more prevalent in female patients, more prevalent in body mass index more than 50, more prevalent in history of previous gastric bending, and those who had type 2 diabetes, because type 2 diabetes may recur, and we have strategies after sleeve gastrectomy to help with this problem. As I said, revision rate is about 12% over 10 years. Interestingly, in France, they only have more or less one strategy for revision, which is gastric bypass, and 3/4 of them. Re-sleeve is number 2 strategy, close to 20%. And the reason for revision are persistence of obesity, not GERD. GERD is only 5% of all the revision. So if we look at 5% of 12%, that's 0.6% of all the sleeve that gets revised because of GERD. But the revision carry a big complication, 5% leaks, 18% bleeding. So, you don't want to get into this. I think the problem with this paper is that Often we say that sleeves get revised when we do BMI more than 50, but I would say that body mass index at 50, the patient should be done in 2 stages. Body mass more than 50, sleeve alone is not a good operation, and the patient should be told that there's likelihood that a second procedure will be necessary after we've decreased the risk of an anastomotic procedure. Also, Roux-en-Y gastric bypass is not a good option for revision for weight regain after sleeve, and I will show you some evidence on this. There is over time, as you know, stretching of the stomach. It stretches as such that if you have measurements of the volume, 124 ml at 1 month, it is now 188 ml at 12 months. So there's a 50% increase in the volume over 1 year. And it usually doubles at year 2. This increase in volume is proportional. The antrum and the body is increasing proportionally. So it's not that one size increases more than the other. It's quite rare that one step will increase. And of course, the percentage over time will decrease as the volume increases. So we know from Dr. Himpens that the percentage of excess weight loss at 6 years has decreased, and the culprit is often the distension of the sleeve. In this paper, it was mostly the fundus, because at the time when those sleeves were done, in the early 2000s, the fundus was not dissected carefully. So when you do your sleeve, you really have to dissect the fundus carefully. It has to be dissected, the fat pad, especially in males, that surrounds the fundus, to see well the junction of the esophagus and the stomach. And I dissect this, and you can see here there's a triangular portion of the fundus that is resected, that otherwise a lot of surgeons would go left to the fat pad and will leave in place. This can increase reflux and can increase weight regain over time. I think a nice paper from the Langenbeck's Archive of Surgery in 2016 has really summarized the steps, important steps of the sleeve, using a bougie that is around 40 French to avoid strictures, transect at a distance from the pylorus, not at the pylorus, use the appropriate color. Mostly, often we'll use 2 or 3 colors as we go, depending on the company you're using, and reinforce the staple line either with sutures. If you have buttress, it's probably good. If you don't, use the sutures to reinforce, and assess that all the staples are complete. We've seen some at the beginning where you only have 1 or 2 rows, and that you should reinforce with sutures. The crotch staples, that has a relatively low evidence, proper traction, not forceful traction, because this can lead to strictures or twist when the traction is unequal, and stay away from the angle of His about 1 centimeter. That has a level of evidence of 1, and check for bleeding in the staple line, of course. And I do an intraoperative blue test, not necessarily to detect leaks, but it gives me an idea if the sleeve is cylindric, if there's any areas of narrowing. The passage of a tube for a leak test will tell you right away if there is a stricture or an obstruction of your sleeve, that it can tell you right away if there's going to be a problem. Let me show a video at this time. I have to go to share. You can see this, I think. This is video of my technique. It dates a few years, but it's essentially the same thing. We use trocars in the belly button for extraction of the specimen, in order to avoid infection and stretching of the muscles. The thinnest part of the abdomen is at the umbilicus. Mobilization of the greater curvature is done with energy device. I don't think it makes a big difference between ultrasonic energies or bipolar. They're mostly what makes you comfortable. Here we dissect the left crus, and it's a dissection of the fat from the crus. This is done carefully. It can start at the bottom of the crus going upward. Here we're going towards the downward towards the pylorus. I will stop about 1 centimeter from the pylorus when I do my dissection. And that is because the stapler comes some distance away from there. You can see the pylorus. And then here's a better dissection of the left crus. And this is where I will assess if there's a hiatal hernia or not. I don't dissect the right side for a hiatal hernia, but from the left side, you can assess here there's some looseness at the base. Sometimes there's fat, and fat is also a hint lipomas present that you will need to do a hiatal hernia repair. As you become more and more experienced, there's an increasing need for closing the hiatus. Here you can see that we've positioned the tube. We will staple here that this is done with buttress, sequential, and I take time. The first one I will usually compress for 1 minute to 2 minutes. I think compression time is important. People go too fast. It avoids getting bleeding. It gets proper compression of the tissue, especially when you're closer to the pylorus. You have to use the high staple height. And this is the second firing. And then we go, I think I will advance the video for the reason of the time. And then we go towards the last firing. On average, there's 5 firings. It can go from 4 to 6. Then I add some sutures at the last and first centimeter and do a buttress with the fat pad that I have dissected anteriorly. I use this as a fat pad, and this kind of a buttress that prevents tissue or the left crus to stick to this staple line. Then there's a leak test. I will remove that from the video. Here's opening of the lesser omentum, and then dissecting the right crus. Again, it's a dissection of the crus, not a dissection of the esophagus. We leave the fat on the esophagus itself that protects from injury to the esophagus. And then opening the space and closing this with non-absorbable suture is done at the same time. You can see the crus, the vagus nerve. Usually this closure adds another 5 to 10 minutes to the procedure. I do some traction so I get more room for the closure. Here, important not to go too deep, not to take, or because the aorta is behind on the left side and the cava is not far from on the right side. This is a figure of 8, and that completes, the procedure. And then extraction of the specimen through the so I will go back to a few slides that I want to show you. Re-sleeve for distended. This is a study that was done with Dr. Noel as was a co-author. This is 52 patients who had a re-sleeve, and you can see that re-sleeve is capable of decreasing 10 points of body mass index. There's been multiple studies now published, and in fact, there is a meta-analysis showing 60% excess weight loss at 5 years with re-sleeve. So this is an acceptable option if the volume is more than 250 ml. This is the meta-analysis that was done by Alberto Aiolfi. You can see the 5 studies that have been 10 studies over 10 years of 300 patients with re-sleeve, 51 minutes to do, 2% of leak, hospital stay 3 days, and 62% of excess weight loss. I think it is acceptable to consider. A SADI as a second step for the revision of the sleeve is, in my view, the best option for weight regain after sleeve. You can see here that you achieve 75% of excess weight loss, so it's a bit better than re-sleeve. And if you break down the body mass index less than 50 got nearly 100% excess weight loss, and the body mass index more than 50 were closer to 67% of excess weight loss. If we compare single anastomosis SADI versus single anastomosis bypass, which one is better? There's not a randomized control trial, but this is the best one, 42 patients in each arm in Germany, which shows that the SADI is slightly better than sleeve gastrectomy. In terms of percentage of excess weight loss, you can see that already at 3 years, the curves are diverging and SADI is better. Not only that, there is severe bile reflux in 1/4 of the patient who had a single anastomosis gastric bypass versus 4.8% with the SADI. So this is an important finding. The patients have poor quality of life when they have a single anastomosis gastric bypass after that. What about SADI versus bypass? This is a multi-center cohort study, very well done in the Netherlands. And you can see that single anastomosis was way better in percentage of total body weight loss compared to Roux-en-Y gastric bypass. The vitamins were, some of the vitamins were worse with the bypass versus the SADI. Just anemia was slightly more with the SADI, but some of the vitamins, for example, B12, was worse with bypass. So my take on all that, on an imperfect sleeve, I would say, is dilatation of the sleeve on someone who had a BMI less than 50 to start with. Re-sleeve is a good option with 10 points of body mass index drop. The regain without dilatation in a BMI less than 50 or has recurrence of type 2 diabetes, I would go for SADI. It is much better than Roux-en-Y gastric bypass. The patient has severe reflux, you only have one option, and that is Roux-en-Y gastric bypass, but it's not going to be that good for weight regain if they have severe reflux at the same time. Body mass index more than 50, then SADI is probably the #1 procedure at this time. We don't know if it's going to be better than DS. It's probably going to be a bit less than DS, but you still have the option to do a full DS as a third option later on. Thank you very much.
Thank you so much, Professor Michel. And we are going to keep the discussion at the end of our session. Our next presentation will be with my colleague, Dr. Ali Al-Muntashiri, consultant and general MIS bariatric surgeon. He is the program director, head of bariatric surgery unit, and deputy chairman of specialized surgical center in King Abdullah Medical City in Holy City in Mecca. He is also Arab and Saudi board in general surgery, and did his minimal invasive bariatric surgery fellowship in McGill University, Montreal, 2012. He's our secretary president of the society, and his contribution and his partner in Mecca in the Holy City with me growing up the bariatric surgery. He will have a talk about the golden standard bariatric operation. Is it there? Dr. Ali, the floor is yours.
Hi, good evening, everybody. I'd like to thank the organizing committee, our colleagues in society for this nice conference and giving me a chance to be part of the speakers. And I welcome our colleague guest speaker from outside Saudi Arabia and also attendees. I'll talk about is there a gold standard bariatric operation, which is this is one of the topics that over years every decade it comes to think that there is one single good bariatric surgery. So on overview, it's obesity is increasing in the last 4 decades, and especially in our country, in Gulf region and in Saudi Arabia especially. It's rising. It's almost 70% overweight, and more than 30% necessitate or need treatment, and that's increased demands on our healthcare services. We have a lot of factors, which is physical activity, sedentary life, abnormal bad eating habits, fast food. That's this increased residence. Now, when we talk about bariatric surgery, this is old classification, but I think it's still there, which is either selection of restrictive or malabsorptive bariatric operation. There is a lot of bariatric operation has been tried and done, but the most commonly performed recently, which is the laparoscopic gastrectomy, gastric bypass, single smooth gastric bypass, SADI, or pancreatic diversion. There is other bariatric operation which is less done, especially in our region. When we talk about what the best bariatric operation, choice of operation. The choice of operation, when we choose operation, we have to look out safety profile. It should be low morbidity, low mortality. The second thing, it's efficacy. We'll look at the long-term effect in terms of weight reduction and also resolution of comorbidity. Other things important is quality of life. Other less side effects, less the patients they do the bariatric operation to have less medication. For example, diabetic patient, hypertensive, they don't want to be also in other medications. Provide low rate of reoperation. The patient wants.
Ali, do you share your slides, because we cannot see your slide if you are sharing?
I'm sharing. Just for a while. I'm sharing my slides. Let me do it again. Why don't told me earlier?
I thought you just.
No, I'm so
okay.
Sorry.
That's fine. Yes, now yes, we are okay.
I'm so sorry. I have to go back, but I will not repeat what I say. Okay, so. Okay.
We lost your signal. Yes, now you are okay. Yes.
So I mentioned it was started about the correlative factors of the morbid obesity in Saudi Arabia and in Gulf region. Then we talked about the different types of bariatric operation. This is the choice of the procedure. What are the criteria we are looking as a surgeon to choose the best bariatric operation?
Dr. Ali, the sound is little bit not clear. في كده echo عندك. أيوه كده.
I don't know. Do you hear me now?
Yes, now it's okay. Continue.
So these are the factors that might contribute or important for choice of bariatric operation, the best bariatric operation, or for the best patient. First of all, we mentioned that it is safety profile, efficacy, and the quality of life, and should have low rate of reoperation, should be reversible and reproducible. You don't know what can happen. So, it shouldn't be. I mean, if these criteria is happening, that's the good operation. We know that restrictive operation is safe, quick, and easy to perform, like sleeve gastrectomy, though sleeve gastrectomy have some metabolic effect compared to complex procedure like coronary bypass, anastomosis, BBD, or SADI. But on the other side, the long-term outcome is higher with this operation. So the safety profile, almost all the bariatric operation is safe with low mortality and morbidity. There is look into factors that evaluating the mortality and morbidity. It's related to the skills of surgeon, available facilities, and type of the patient, type of the procedure that might contribute to complication and mortality. Overall, bariatric surgery is safe, less than 1% mortality at 30 days. Now, we've looked into the long-term outcome. The first one is we look into the weight loss. Weight loss, the effectiveness of the bariatric surgery looked into, first of all, either excess weight loss or total body weight loss, and the second part, it is the resolution of comorbidity. This is the effectiveness, how to be measured. We've looked into previous meta-analysis and systematic review done by all our pioneers in bariatric surgery. We can see that bariatric surgery is the best method of weight loss, achieving more than 60% with different range. Malabsorptive have higher rate of. Now we looked into different types. We looked to the sleeve gastrectomy. Sleeve gastrectomy is a very good operation. It is originally performed as a part of component of the dental switch procedure, then become a standalone operation and considered restrictive, but it has some metabolic effect. It has very excellent efficacy profile at least in the short term, 3 to 5 years. Still, we have a good result, ranging from 60 to 80 to 90% excess weight loss, and also resolution of comorbidity. Even after 5 to 10 years, still we have good results. The other thing you can see that also the studies done about comparison by Dr. Phil Shower about 3 years, 5 years, 1 year, 3 years, 5 years about efficacy of bariatric surgery, and sleeve gastrectomy is a part of that. That still have its excellent metabolic results. So it's safe operation, quick, good weight loss, and good resolution of comorbidity. Now, when we look at to complication, sleeve gastrectomy is very safe operation. In the past, leak was one of the major issues, and it's still there, but it is coming less with advancement in the procedure, advancement in the stapling techniques, advancement in the buttressing material, and skills, more training centers and more skills. So the complication is less operative complication. Long-term complication, when you look at sleeve gastrectomy as metabolic or nutritional consequences, is less than compared to malabsorptive procedure. The only concern is GERD. The two major concerns of sleeve gastrectomy is weight regain and GERD. And we know the big fuss and the big discussion happened the last 2 years about GERD and paraesophagus incidence after a sleeve gastrectomy, and this is the issue. We know that the proposed that there is narrow tube, increased intragastric pressure, maybe destruction or the mechanism of anti-reflux mechanism obstructed during the procedure. So these all factors might increase the incidence of GERD after sleeve gastrectomy, and became a big concern as a big drawback against sleeve gastrectomy. This other factor, the other studies looking that maybe the GERD might be resolved or improved after sleeve gastrectomy, but it's not that strong evidence. When you look into gastric bypass, it is another mixed restrictive and metabolic surgery with good safety profile, excellent excess weight loss, and even after 10 years, still we have good weight loss, though there is a drop in the percentage and less complication. The only thing that gastric bypass, you can see it's associated with increased internal hernias, which is the concern, and a few patients end up with total bowel resection. marginal ulcer, and anemia. These are the major issues after gastric bypass, and make the selection also difficult in some patients. Now, we're looking to one anastomosis gastric bypass. This is another emerging procedure, which is almost now 20 years on the effectively been done, and it's increasing. It's a good operation with good safety profile, excellent excess weight loss, excellent comorbidity resolution. The other thing is the presence or the effect of bile reflux. Bile reflux is the major issue. It is different incidents in different studies, but it became the major issue. And if we looked into different schools, mini bypass or one single anastomosis gastric bypass funds against Ronoy gastric bypass funds, we can see that the dilemma around bile reflux and definition of the bile reflux and the incidence of the bile reflux. But still, it's safe profile, less operative time, and excellent weight reduction. SADI is excellent operation with good metabolic and weight loss outcomes. The only thing is the metabolic consequences. It has major nutritional deficiency. I know Dr. Gary might agree with that, but there is a lot of studies showing that protein malnutrition, vitamin deficiency, needing lifelong supplementation. So when we have to compare between the the four major operations, as I mentioned, safety profile, efficacy, complication, quality of life, reversibility, we can see that the sleeve gastrectomy is safe, excellent weight loss, less mortality, less nutritional deficiency, good quality of life, and unfortunately, no reversibility. GERD is the major issue. Ronoy gastric bypass, marginal ulcer and hernia, and it has a good safety profile, single anastomosis and SADI associated with higher malnutrition and so how we gonna choose bariatric surgery? Now, if we looked into the factors that affect the weight loss or weight regain after gastric bypass, that make us select our procedure based on our patient criteria. We don't select the procedure based on our preference. What if I like to do sleeve gastrectomy, I will do the sleeve. I like to do gastric bypass, I just do the gastric bypass. I think it's important to tailor the procedure based on the patient factor. There is a hormonal factor, dietary factor, presence of comorbidity, BMI, age, sex, all these important to take in consideration before selection of different bariatric operation. So there is there a standard bariatric operation? There is considerable variability in the weight loss following bariatric surgery. Whether restrictive or malabsorptive, restrictive have less weight loss or less long-term outcomes versus malabsorptive. The long-term outcome is important to take into consideration. You have to know that same patient do very well and some do less. The patient will benefit, but the benefit will be different from patient to patient, and the amount of weight loss is different from one to other. So there is no single magic bullet for obesity. So we have to understand there is no single magic bullet for it. We have to think about all others variables. We have to think about all other procedure. We have to tailor our strategy or management steps based on the patient variables. Thank you.
Thank you very much, Dr. Ali. And sorry for the beginning of your slide at the beginning. So our next speaker is Dr. Osama Al-Sani, General and Laparoscopic Pediatric Metabolic Surgeon, who had his degree from Kuwait and American Board of Surgery from Tufts University Hospital in Boston. He did his fellowship also in laparoscopic and bariatric surgery there. And he is one of the senior bariatric surgeon who is contributing also in the workshop and to many teaching and mentoring of bariatric surgery in Saudi Arabia. Dr. Osama worked as a consultant and minimal invasive bariatric surgeon in private sector in Al-Dhahran Hospital in Al Khobar. Dr. Osama, the floor is yours.
Thank you. Just to let you know, we are now at Al-Mashfa Hospital. It is the dedicated bariatric facility where I practice from. Most of the things we do in life are usually out of necessity. I have been in private practice for 20 years, and after a period of time with financial constraints and reduced pay for our bariatric procedures, I elected to go ahead and open my own center. So I have better control on the quality of work that I do for my patients and to start a program. So let me share with you a presentation. This presentation basically is the result of the work that I have done along with my colleague, Dr. Abdulhamid Al-Momin. And we were recently joined, after a while, we were joined by our bariatric dedicated anesthetist who's joined us. So the presentation will encompass the three of us. Let me share my screen now. Sorry. Okay.
Can you make it full screen?
Yes, I'm going to make it a full screen. So basically, our topic is enhanced recovery after bariatric surgery, and it's Al-Mashfa experience. Here's our dedicated team. We have a full dedicated team to what we do in the center. We're fully dedicated to bariatric surgery. So initially, in my opinion, I thought that ERAS was fast track, simply just a fast track to get patients out of the hospital so I can get more advantage of taking care of my patients, and at the same time, improve the revenue for the center. And that was the gist of it for me in the beginning. So I went and looked at the history of ERAS. I looked at it, in fact, for this presentation. And let me tell you, so I found out that in 2001, 2 surgical nutritionists were interested in the care of patients who have cachexia. So they focused on improving their perioperative care through nutrition. And they worked hard so that in 2010, they established what we call an ERAS Society. The ERAS Society, in fact, remained focused on cachexia and cancer. They wanted to reduce the complication length of stay, so they elected to start with a protocol that is prolonged, such as colorectal surgery. It was only in 2016 that I saw the first glimpse of people working with ERAS in bariatric surgery. And it was done also by the Surgical Metabolism and Nutrition Society. The president of the society was a gastric surgeon, Anders Thorell. There's a misspelling, I'm sorry. He wrote the guidelines for perioperative care in bariatric surgery on the ERAS protocol. That was published in the World Journal of Surgery in 2016. So it wasn't in a bariatric focused journal or for the society. So why the delay in adopting ERAS in bariatrics? I think most surgeons are concerned about the patient preoperative comorbidities and whether it justifies putting a patient on an algorithm or a protocol. And then also the society and the general community, and even including our surgical colleagues, do not tolerate a complication when it happens in bariatric surgery, while they would tolerate it in any other specialty. So I looked up the first protocol that was written about ERAS. It was done in June 2018, and it was truly a fast track protocol. The goal of the protocol was to reduce perioperative opioid consumption, postoperative nausea, so you can get patients out of the hospital. That was published in the ACMS. So is fast track even acceptable? Conventional surgery dogma is basically prolonged fasting, a lot of drains, a lot of catheters, watch patients for complications, so make sure he doesn't leak, he doesn't bleed, etc. He doesn't have PE. So usually you want to just sit and watch them for a few days until you're happy to send them home. Well, I think in general, I think 2 societies that I'm a member of, SAGES and ACMBS, I think they broke this dogma and changed it. I think we owe it a lot. Laparoscopic surgery has revolutionized surgery, and one has to really admit and accept that as a fact. I started looking at this, whether it's a fast track or not, and it basically, to me, it was basically load them with carbs pre-op, improve their intraoperative situation, whether me or the surgeon, and at the same time, post-operatively get them out of the hospital by early feeding and let them mobilize early. I wasn't really interested in functional outcomes and what happens to them afterwards. To me, ERAS just simply was there. This is a cartoon which says, a patient would ask you and say, would I ever be normal again? Go back to work, practice, not feel sick. And we as bariatric surgeons, we're often interested in telling the patient, you've eaten enough in your life, let's fix you now because we want to fix your comorbidities. And we really have to listen to the patient that he wants a quality of life. And this is something that we need to be concerned about. So the pre-hospital and the post-hospital part of ERAS is what we will focus today on, trying to show you that it is a lot about functional outcome and trying to rehabilitate the patient to get him to the best outcome for you. Because those patients linger with you for many years. And if they're sick, they'll come back to you. So the ERAS protocol is a patient-focused protocol. It's standardized, it's evidence-based, and it is truly interdisciplinary. It is not early, it is enhanced. And that is the difference from what I have learned at the end. The benefits, the patient would benefit, it becomes convenient for him. It will attract more patients, and it has helped us attract more patients. It helps the hospitals manage cost and beds, and we've seen that in our across the board for us. Third-party payers would work better with us, and then sick time would be reduced for patients. Well, the goals of ERAS, yes, early discharge remains a goal of ERAS, but reducing the surgical response, making the bodily functions, whether simply as defecation or tolerating oral intake, and also being functional, able to walk, take care of your family, not faint, and not be able to be fired from work because you're not eligible or you're not fit to go for work. Those are important issues that we have to contend with as we provide treatment for our patients. And I'll show you the full functional. What I'm talking about is these are two patients and both lost weight, but one is happily ever after, as they say, and one is suffering the result of it. So now I'll turn the microphone to my colleague and the presentation about ERAS, how he changed our minds.
Thank you, Dr. Osama. Thank you, my dear colleague surgeons. I'm maybe the only anesthetist here, so bear with me for the coming 10 minutes. You will not regret. First, when I practiced bariatric surgery 2010, and as pain is the most important determinant of recovery, fast recovery. I practiced the oblique subcostal tab block in bariatric surgery and published a study in 2014. And in surgery for obesity and related disease, a review article about the use of oblique subcostal tab and demonstrated its efficacy in decreasing pain and subsequent narcotic consumption. When I joined the Al-Mashfa Medical Center and started to convince with Dr. Osama about the feasibility and how to we start the ERAS protocol, and we started only with the oblique subcostal tab block. He is encouraging us and giving full support to me. Soon we started to identify the key champions. Dr. Osama, after a few cases, he realized and sees the response of the patient. So we started to identify the key champions of the teamwork. Dr. Osama trusted me, the administration, and being involved in all stages of the ERAS protocol, I carried out the responsibility. I started to assemble my task force group.
Please unmute yourself. I think by mistake you mute yourself, Doctor. Dr. Osama?
Okay.
Yes. And please be cautious about the time because we still have 2 more presentations to go.
I assembled my task force group with series of meetings and orientation for the team. Now we want to have a written protocol. After 3 months, we have now a complete protocol, written protocol for ERAS protocol from pre-hospital to late post-hospital phase. One of the most important components of our ERAS protocol is protocol for post-operative analgesia or perioperative analgesia. We decreased the narcotics usage to the minimum with fentanyl and bethadine and fentanyl by the use of oblique subcostal tap block. Here is the technique we are using. We are for all patients who are performing this kind of block between the transverse abdominis muscle and rectus muscle. This is a spread of local anesthetic. Once one of the most important also component is anticoagulant prophylaxis. We are giving preoperatively for high-risk patients a history of DVT, BMI more than 50, and cigarette smoker, contraceptive pills. And all patients started the anticoagulation prophylaxis 24 hours after surgery. Of course, all patients early mobilized and mechanically prophylactic. After a block, we realized that we have decreased, as you see in the diagram, we decreased the narcotic consumption to the minimum. For education is a continuous process. We make a rebrand and videos for orientation of the patient and family all through the whole program, stages of the program. So, functional capacity, we have an outcome for the ERAS program. This early outcome, intermediate outcome, and late outcome should have forms to document our documentation process. Furthermore, we want to decrease the perioperative narcotic consumption. We started our new randomized control trials. We recruited 108 patients and randomized 103 between two groups. Our primary outcome was the quality of recovery after 6 and 24 hours. The secondary outcome was opioid consumption, function recovery, and CHAR. Each group, multimodal analgesia and opioid-free analgesia groups. We replaced narcotics, fentanyl, with some medication which has analgesic efficacy like ketamine, dexmedetomidine, and xylocaine. All patients received oblique subcostal tap block. As we see here, the numerical rating scale. There is the opioid, it shows opioid-free analgesia, reported less pain intensity in all times of the interval, all time interval post-operatively. The post-operative quality of recovery, there is the superiority of opioid-free analgesia, superiority of opioid-free analgesia at 6 hours that disappear after 24 hours. Regarding the narcotic consumption, there is a significant reduction of narcotic consumption in the perioperative period. PACU, ward, surgical ward, functional bit, although the opioid-free anesthesia group showed better analgesia but stayed longer in PACU. This may be due to ketamine and shorter operation time. Regarding function capacity, we see the opioid-free anesthesia group had early functional recovery, early fluid tolerance, and early readiness to go home. So our plan, we adopted the opioid-free anesthesia. We adopted our ERAS program for all kinds of surgery, included revisional surgery. Classical surgical outcome as equal as the functional outcome in the post-operative period. The patient regained its functional capacity. This one 300 kg patient operated and ambulate in recovery room after 40 minutes. So what's the benefit? What is total value? What to have total value? Quality, safety, by patient satisfaction over cost. I think you can translate it to money and time. In our conclusion, that many patients are afraid to understand and undergo surgery due to concerns about functional capacity. Due to ERAS, we increase the safety of bariatric surgery and the volume of our patients increased and patient comfort. Thank you for all. Thank you.
Thank you very much,
I think
Dr.
that's our
Osama.
presentation. Thank you.
It's really congratulations for your successful story that you could really convince your institution and to have this ERAPS completely implemented. Our next speaker will be Dr. Carl Lirokas. He will talk about the post-operative care and follow-up after bariatric surgery. Dr. Carl, he's a consultant in metabolic. He's a consultant in metabolic medicine and physician with an interest in the obesity. He is a leader in metabolic medicine at Imperial College in London. He is specialized in managing the patient prior and after bariatric surgery. And he is also subspecialized in pharmacotherapy and to reduce the complication risk and optimizing the health benefit of weight loss. Dr. Carl, the floor is yours.
Well, thank you for that lovely introduction. And my name is Carl LaRue. I'm a clinician scientist that work at University College Dublin and Ulster University. So these are my conflicts of interest. And we work with lots of different companies, including surgical companies, medication companies, and nutrition companies, because we don't think that there's only one solution for people with obesity, and therefore we think there's a combination approach that is required. But here is the challenge for personalized medicine and the pre and post-op care for people with bariatric surgery. If you have a clinic, patients come to the clinic, you give them the treatment, and typically the treatment doesn't work, or they think you have cured obesity, and they come back to the clinic, you try another treatment, and it may or may not have worked. For example, people have weight regain, and at some point, the patients stop coming to clinic. And this is not a strategy that is helpful if we just try to apply this. So what we really need to do is to change our own minds as well as the minds of our patients to focus both pre-operatively and post-operatively, not only on morbid obesity, but to change those words around and to focus on obese morbidity. So we are not thinking about bariatric surgery as weight loss treatment. We think of bariatric surgery as health gain treatment. And then we have to ask ourselves, which diseases and complications of obesity are weight sensitive, which are weight resistant, which are non-weight related, and which are therapy specific. We also have to ask ourselves, how much weight does somebody have to lose for them to become healthier? And we can see that very often with the metabolic changes, only a small amount of weight loss, 5 or 10%, is enough. But when it comes to cardiovascular risk, or even the amount of weight that we need to change for somebody to think of themselves as healthier, now we are talking about 15% weight loss. And that certainly is only possible at the moment with bariatric surgery, albeit that we hope that we will have medication soon available that can help that as well. However, when we ask patients about their quality of life, what we very often hear is that it relates to the activities of daily living. And people say to us, doctor, I can't sit on the floor and play with my children or my grandchildren. I can't bend over and cut my own toenails. So these activities of daily living that many of us take for granted, these are the activities of daily living that drives quality of life. And to do that, we need 20% weight loss. And of course, so many of our patients come to clinic because they want to become thin and they want to become happy. And very often we disappoint patients, or even after they've had really good treatment, if they've lost 25 or 30% of their body weight with a surgical treatment, they would still say, I don't see any difference when I look in the mirror. So we need to work out and be very clear with our patients, what can we do and what can we not do to allow them to have their expectations calibrated both before as well as after bariatric surgery. So before bariatric surgery, we use the Edmonton Obesity Staging Score, and we think about these 4 stages, stage 0, 1, 2, 3, and 4. And really thinking about this in the way we think about cancer in tumor node and metastases. So we understand that the biggest cancer is not always the most malignant cancer. A cancer that is T3N0M0 is bigger than a cancer that is T1N1M1, but the latter smaller cancer is more malignant. In the same way, we need to get away from thinking that body mass index is going to tell us about obesity, but rather we need to focus on these medical, mental, and also mechanical complications of obesity. Now, we've converted this into the King's Obesity Staging Score to allow us to cover all of the important domains before surgery. But we use the same score also after surgery to see how effective our treatments has been. So this is the baseline strategy that we have for both the preoperative and also post-operative assessment of patients for bariatric surgery. So we think about the domains in an alphabetical order so I can remember it in clinic. So airway, body mass index, cardiovascular, diabetes, economic complications, functional complications, gonadal, health status perceived, which is quality of life, or image. Now we've gone further and also looked at junction of the gastroesophagus, kidney, liver, and medication. And then we stage it in stage 0, 1, 2, and 3, where stage 0 is normal health, stage 1 is at risk of a disease, stage 2 is an established disease, and stage 3 is a complicated disease. Now, what this allows me is to downstage the obesity in the same way as we do for cancer. So if you've got a T2, N1, M0 cancer, what you want to do is you want to turn it into a T0, N0, M0 cancer so that you can give the patient the best chance of long-term remission. And that's what we want to do with this stage. We want to downstage it to allow our patients to become free of the complications of obesity. So let's focus on A for airway. And this is a randomized controlled trial between surgery and best medicine, looking at the apnea-hypopnea index. So we want to identify patients with sleep apnea before, and then we want to track them afterwards. And what you will see from the surgical cohort, that we are very effective at reducing the apnea-hypopnea index, much more so than in the medical cohort. Unfortunately, the majority of our patients after surgery still have an apnea-hypopnea index above the threshold of them needing CPAP. So now, at the moment, what's happening is a lot of patients the CPAP is being stopped. But I think we need to assess these patients to make sure that they cannot, that we are not stopping it wrongly, and that they may benefit from continuation of sleep apnea treatment. So we can see the first complications. We have to be humble and to say that we may not be quite as good as we thought we were when it comes to sleep apnea. And we need to assess patients both before and afterwards. The next one is body mass. And of course, surgery is the best way not only to achieve substantial weight loss, but also to maintain the weight loss in the long term. But what we see is that there's a normal Gaussian distribution of weight. And therefore, we have some patients in our clinic that lose 40% of their weight, and other people who only lose 10%. And it appears that none of us are smart enough to identify the patients preoperatively who is going to go on to lose 40% of their weight and or those that are only going to lose 10% of their weight. We thought that the smart people who listen to us are going to lose more weight, and the people who don't listen to us will not lose as much weight. But it turns out when we test this prospectively that we are not successful enough at predicting this. But what we do see is that these groups do exist. There are some people who have a very good operation, such as a sleeve gastrectomy or gastric bypass, who go on only to lose 10% of their weight. And there's other people who go on to lose 45% of their weight. And although we can't differentiate them very early on in the first 1, 2, or 3 months, it certainly appears that at about 6 months, we can start predicting who is not going to lose as much weight as anticipated. And therefore, it allows us to identify these people earlier and to start intervening in them much earlier. Because the most successful way to predict which patients are going to lose, how much weight somebody is going to lose, is to ask them if they had a first-degree relative who have had surgery. And it turns out that in those people who've had a brother or sister or a mother or father who've had these operations, they are the best predictors for weight loss. Even when people live in the same house, when a wife and a husband gets the operations, their variation is the same as the rest of the family. And the reason is that we now understand that bariatric surgery works by changing the neurological disease of obesity. And if we understand that the nucleus tractus solitarius interacts with the arcuate nucleus, for example, these are all subcortical areas of the brain, then we can understand why surgery is so effective. But it also is true for diets and medication. It only works if people feel less hungry and more satisfied. And that's the most intriguing thing about surgery, is we never have to ask somebody who've had surgery to try and lose weight, because they do this automatically, because the surgery is working through physiology, not through volition or by increasing the patient's motivation. So thinking of this in another way, we think of this as a set point. So if you live in a bad environment where you don't have a good diet, you don't sleep enough, you don't have enough exercise, your set point for your fat mass is going to increase. But if you have a good treatment, such as a lifestyle treatment or medication, or even better, a surgical treatment, we can reset the set point in the long term in the majority of cases, not everybody, but certainly in the majority of cases. So C is for cardiovascular, and what we now know is that surgery allows people to have fewer heart attacks and live longer. So we see a 25% reduction in cardiovascular events, and those patients that have type 2 diabetes appears to benefit even more. Why is that? Because surgery also treats the diseases that leads to cardiovascular disease, for example, such as hypertension. Or we can understand that this is not only through weight loss, it also includes the non-weight loss related mechanism. For example, here, increase in urine sodium excretion after gastric bypass that is not seen after gastric banding. But now we are becoming more confident when we think about the major, adverse and cardiovascular events, for example, myocardial infarction, coronary vascular events, and death and strokes, for example. And we can see that metabolic surgery is far better than those patients that don't have surgery. And now in my clinic, when I explain to patients the risks of surgery, I make it very clear that the risk of not having surgery is very often higher than the risk of having surgery. And that allows people to put this in perspective and to work out what are the right steps for them. So D is for diabetes. And in the randomized controlled trials that we have, more than 13 randomized controlled trials now, we can see that surgery always outperforms lifestyle and medical therapy when it comes to weight loss. But surgery in people with diabetes also has a dramatic impact on glycemia, as well as lipids, as well as blood pressure. So diabetes is not about sugar. Diabetes is a systems disease. And what we can see is surgery addresses all of these systems. But not only does it work in 1 year, here I'm showing you the 5-year data of the STAMPEDE study, both in sleeve and bypass, showing how much better it is than even our best medical treatments. And that's why we are now calling for people with diabetes, even when they have a body mass index between 30 and 35, and they are not well controlled, to be considered for surgery. So we would like patients with diabetes to be prioritized, because all of the studies show that they appear to benefit even more than our other patients. So I'm going to summarize and say bariatric surgery will not make you thin, and it will not make you happy. But what bariatric surgery will do is it will make you healthier and more functional. And this is the shift that we have to do preoperatively so that we can allow our patients postoperatively to benefit from this. So in conclusion, Metabolic surgery has major benefits. On the symptoms of obesity, it makes people feel less hungry and more satisfied. It prevents the complications of obesity. It prevents cardiovascular disease. It prevents cancer. And also to treat the complications of obesity. It can take type 2 diabetes and put it in remission. It can improve the functionality of our patients. A change in approach is, however, needed to be more similar to cancer surgery, how we are thinking about downstaging a disease and then keeping it in remission in the long term. And therefore, we are advocating more combination therapies of surgery together with medicines. But a personalized medicine approach is now needed to get the right treatment to the right patient at the right time. Please allow me to thank the team at home that's doing all the hard work, especially our fellows from Saudi, so Dr. Heshma, Dr. Muath, Dr. Matip, who are all really contributing, during their fellowship at our service. And finally, also our international collaborators, many of whom are here today, so Dr. Al-Katani, as well as Dr. Galia Abdeen, who have been fantastic collaborators in the long term. So thank you very much, and I'll leave you with our website, which is itsnotyourfault.ie, where we are explaining to patients that obesity is a disease. It's a disease that's not their fault, but it is their responsibility. And it is my responsibility to find a treatment that helps them in the long term. And we think surgical treatments would be an excellent example of such approaches. Thank you very much.
Thank you very much, Doctor, and I apologize and sorry regard the introduction for your bio that it was my mistake. And our next speaker, Dr. David Cumming, a professor of medicine in the Division of Metabolism, Endocrinology, and Nutrition at the University of Washington. Dr. David, his major current focus of research into elicit the hormonal and metabolic mechanism mediating the profound effect of bariatric and metabolic surgery on diabetes and the body weight, as well as determine the role of surgery in diabetes care through many randomized controlled trials. He also clarify and seeking to clarify the physiological function of the organics and the hormones. Dr. Cummings, he's also received award-winning honorary and scholarship and many society awards, honorary and scholars, and a phenomenal background regard all of these things. He will delight us today about his presentation. Doctor, the floor is yours.
Thank you very much. I'm just checking. Can you hear me?
Yes, yes, we can.
Okay, I'm going to try to share my screen. Switch the view. Okay, can you see my slides?
Yes, it's clear. You can go.
Okay. Welcome, everybody. Thank you for joining. It's my pleasure today to talk to you about metabolic bariatric surgery in the time of COVID. I disclose that I'm on the scientific advisory boards of these companies, and then let's get going. So back in 2019, with the first emergence of COVID, it very quickly became clear that individuals afflicted with the disease of obesity suffer worse outcomes when they contract the COVID-19 disease. This was first published in The Lancet by people in China, and then very rapidly replicated in the United States, France, the United Kingdom, throughout the globe, et cetera, et cetera. There are now lots and lots of papers that all affirm this same observation, that folks with obesity do poorly when they get to COVID disease. Now, from the very beginning, there was a controversy whether this was because of obesity itself as a risk factor, or because other things associated with obesity lead to bad COVID outcomes, because the latter is definitely true. For example, if you have diabetes or hypertension or various pulmonary problems that tend to accompany obesity, they clearly make COVID disease worse. But some of the investigators of those first publications did various statistical analyses to factor out these confounders and said, well, we think obesity itself is actually a risk factor unto itself. Although those methods for dealing with confounders are useful, I think it's difficult to rule out all potential unmeasured confounders because there's a lot of socioeconomic features that are associated with obesity that could also themselves contribute to COVID bad outcomes. However, there are many plausible mechanisms by which obesity in and of itself could increase the severity of COVID disease. Whether it's obesity itself or something related to obesity that leads to bad COVID, it doesn't really matter. Regardless of the mechanism, having obesity predisposes you to bad COVID outcomes. So with that fact in mind, where does metabolic bariatric surgery fit into all this? I'm going to try to address that question by acting as a spokesperson for a position paper that was published last year on this topic as part of the Diabetes Surgery Summit series of initiatives. Now, DSS, Diabetes Surgery Summit, is not just a single entity, it is a series of projects that have been going on since 2007. Some of the main leaders of them have been Francesca Rubino, Phil Schauer, myself, and your previous speaker, Carl LaRue, has been deeply involved. Periodically, we convene large global consensus development conferences called DSSs, where we try to update the ancient 1991 NIH standards for how to use bariatric surgery and replace that with new guidelines for the use of metabolic surgery that are much more evidence-based and modern. We also have much more frequently related world congresses on interventional therapies for type 2 diabetes, which have various purposes and themes, and we do things in addition that have nothing to do with conferences. And it's one of those last initiatives that I want to talk to you about today, which is a project we did through the DSS mechanism to address how we should prioritize who gets metabolic bariatric surgery in the time of COVID. So these recommendations were put into a position paper, which we published last year in the Lancet Diabetes Endocrinology. These are the authors. I'm the senior author. You can see your previous speaker as the third author or fourth guy up there. And it was published in Lancet Diabetes. As with most Diabetes Surgery Summit series projects, we purposely made the body of experts that we convened for this purpose weighted toward non-surgeons. That was because there is at least the possibility, or at least the perception, that surgeons might have a conflict of interest if they try to promote something that they personally do. So, like with most DSS projects, this one had 74% physicians, internists, non-surgeons involved in it, and only 26% were metabolic surgeons. So here's the kind of logical backdrop to our thinking. There's a lot of evidence indicating that people with obesity and/or diabetes might have a higher risk of contracting the SARS-CoV-2 infection in the first place. And there's no question that they suffer worse outcomes if they get COVID. There's also no question that metabolic bariatric surgery is by far the most effective intervention for both obesity and diabetes. So if you put both of those two facts together, it logically leads to the conclusion that maybe theoretically, we should be pushing for metabolic bariatric surgery more than ever right in the midst of the pandemic, because it's dangerous to have obesity or diabetes when you're living in a COVID world. However, countervailing that particular line of thinking is the fact that surgery itself increases the risk of contagion to both patients and staff. And that's particularly true with metabolic surgery because it involves several procedures that increase the risk of aerosolization of potentially infectious particles. So those are things like pneumoperitoneum, electrocautery, ultrasonic shearing, and upper GI endoscopy, as well as other things. So this particular expert panel of Diabetes Surgery Summit faculty felt that on balance, these immediate risks of contagion to patients and staff outweigh the theoretical benefits of ameliorating diabetes and obesity when infection rates are high. So when you're in the midst of your particular phase of the pandemic, we think that it would be wise to put on hold metabolic bariatric surgery, as is often done for all other elective operations. But most of us are getting through this, and the infection rates are coming down, and ultimately COVID will pass. So when the COVID pandemic eventually abates and elective operations, including metabolic surgery, come back online, there's going to be a large backlog of patients seeking metabolic bariatric surgery. Delays in that timing because of the big backlog, they're going to harm some patients more than others, depending on their burden of obesity-associated diseases. And the traditional weight-based criteria for surgical selection really don't address this situation. So our group offers a strategy to how to prioritize metabolic surgery based on the burden of metabolic diseases most likely to be ameliorated post-op and to do damage if delayed. To get to this prioritization algorithm, we first defined categories of prioritization. So urgent access was, in our words, something where you should have your operation within a month. And that typically is a repair of some complication from a prior primary bariatric operation. The categories we spent our most time are on these two. Expedited access we define as within 3 months, and those who could wait longer. For standard access, we define that as surgery you can wait for up to a year in the time of COVID. So with those definitions in mind, let me now show you the Diabetes Surgery Summit algorithm for prioritization and use of bariatric metabolic surgery during and especially after COVID. For this purpose, we define bariatric metabolic surgery into 3 basic types, depending on the use, the indication. There's diabetes surgery, where the primary goal is to treat that disease. Obesity surgery, primarily designed to promote weight loss. And I'll explain in a moment what adjuvant metabolic bariatric surgery is. For each of these 3 kinds, we figured patients should be distinguished. They should be defined as requiring either expedited access or standard access. And those things would be based on their conditions. So let's just take our first example, diabetes surgery. The group feels that criteria that would qualify a person for expedited access are a list of things shown here, all of which are associated with a higher risk of death and disability. So hemoglobin A1C more than 8 on at least 2 oral medicines, because we all know that high A1C levels are strongly associated with both diabetes microvascular and macrovascular complications. The use of insulin is a strong determinant and predictor of mortality, so it's on the list. A history of other cardiovascular disease, of actual cardiovascular disease, or NASH, or at least 2 other metabolic risk factors known to increase cardiovascular risk. Albuminuria, or stage 3 or 4 chronic kidney disease, not only because it marks the kidneys are in trouble, but this is a very good proxy for cardiovascular disease risk, as Dr. LaRue has clearly articulated. And we put 5 years of diabetes on this list, making it then not 10 years, because after 10 years, the rate of diabetes remission begins to fall off. So all of those criteria would justify expedited access to metabolic surgery. And if your patient doesn't have any of them, that person we figure can wait around for standard access out to a year, because he or she is likely to live long enough to do it and can afford to wait for a year without really getting into trouble until COVID's out of the picture. The same kind of thinking went for obesity surgery. That would be where your primary goal is just weight loss. People would be divided into those justifying expedited versus standard access based on their characteristics. So, for example, expedited access would be justified if a person had a BMI over 60, because these very heavy people have a lot higher death rate. Or again, NASH, or at least 2 other metabolic conditions known to increase cardiovascular risk. Severe obstructive sleep apnea or obesity hypoventilation syndrome, both of which are associated with increased mortality. Heart failure, or again, stage 3 or 4 chronic kidney disease, which is associated with increased cardiovascular risk. If your patient doesn't have any of those things, he or she could afford to wait for standard access to surgery and hang out for at least a year until COVID's gone and there's no concern anymore about contagion to risk to patients or staff. So now I'm going to define what adjuvant therapy is. We thought that we considered that to be metabolic surgery performed to allow a person to have access to some other important operation. So for example, say you have end organ failure and you're dying and you need your transplant, but the surgeon says, I need you to lose a bunch of weight beforehand. So that would be a reason to have metabolic surgery to promote the ability to get your life-saving transplant. Or you need a coronary artery bypass graft or some critical hip replacement or knee replacement. In all those cases, we felt use of metabolic surgery should be considered expedited and put people higher on the priority scheme. Now, there's a lot of information on this algorithm, but as I said, if you look in the lower right corner, this is published in Lancet Diabetes Endocrinology last year, and you can find out the details there. To summarize, though, the basic principle is that we feel that after the COVID pandemic, in the business of tackling the backlog of metabolic bariatric surgery patients who will be around, they should be prioritized based on their burden of diseases most likely to be ameliorated postoperatively and cause harm if delayed, rather than on their BMI, the traditional method we use. And the final thing I'm going to say is the most important thing I want you to take home. Although this triaging algorithm is particularly relevant shortly after the COVID pandemic, there's absolutely no reason why it cannot be used clinically to guide meaningful prioritization of metabolic surgery long into the future, because the principles apply even independent of COVID. As I say, I'm just a spokesperson. These are the authors of our paper. I thank them all for their hard work, and I thank you guys for your kind attention, and that's all I need to say. I'll stop sharing my screen.
Thank you so much, Professor, for this. We all have been through this pandemic, and until now we are still suffering. Otherwise, we should be together joining each other in the meeting now, and you are visiting us in Saudi Arabia. But hopefully that soon will be end soon.
I hope those times return.
Yes, it will. So I would like to start with the pooling selection criteria regarding an update. And I will launch the pooling system now, so that I would like everyone please to answer the pooling, and we will start from there. At your practice, do you offer bariatric and metabolic surgery to patients with class 1 obesity BMI below 35? We will give time so that everybody can answer, and we will end the pool within another 30 seconds, and to start with this first one. Five more seconds and we are closing the pool. Okay, I am sharing with you the result of the poll that 66% answered no and 34% answered yes. So back to the question with Professor Shower and Dr. Adnan. Professor Adnan.
Sure, I'd be happy to start. Can you hear me, Dr. Bhatia?
Yes, we can hear you clearly.
Yeah. So the most important thing is, do we have the science, and then do we have the consensus? Okay, and I think the answer to both of these is yes. I mentioned in my presentation very briefly, there's 12, actually 14 now, small randomized controlled trials. The vast majority of them include patients with BMI as low as 27, comparing surgery to medical therapy for diabetes. And they all show that even in this lower BMI group, they enjoy the same types of improvements in glycemic control as the higher BMI patients, that is above 35. It's also safe in this lower BMI group. That's all of these studies conclude that. And on top of that, so I think the science is there. And on top of that, we have a consensus. This was actually discussed and debated at the DSS conference back in 2016. And the majority of the attendees were not surgeons. 2/3, and David can attest to this, 2/3 of the expert panels were endocrinologists, non-surgeons, and they all agreed that this lower BMI category was appropriate, especially for patients who have diabetes not well controlled. on medical therapy. And we have many organizations like the American Diabetes Association, which is very conservative. And for the last 5 or 6 years, their annual guidelines have said it's okay. It's a good idea to do surgery for diabetes in this low BMI group. Especially in a country like Saudi Arabia, where the diabetes appears to be more virulent than the United States. I'm surprised that there wasn't a higher adoption among the surgeons in this group. But I think we're there. Yeah, and maybe someone else would like to comment.
Yes, Professor Adnan.
Yes, Sam, thank you. I agree 100% with Professor Felshauer. And the problem is that although the issue has been recognized and even supported by our national diabetes society and association, but it's still the matter of the cost and insurance issue and who's going to take the burden for these things makes the utilization of this issue is still underutilized and underused. This is mostly an issue of cost and insurance policies. Still a lot of resistance from the insurance companies, and hopefully things will get to the better and we will go to the lower BMI groups and those who are in need of bariatric surgery for metabolic issues. Thank you.
Okay.
Yeah, Professor Mofty, I'll just comment briefly. We still have access problems in the US, and I think most countries for that reason. While there is consensus, the payers, the insurance carriers have often not adopted yet those standards, but we're making some progress in the US. We're seeing more insurance plans cover the lower BMI, but you are right, we have a ways to go.
Oh, may I make a comment?
Yeah, yes, Dr. David.
So poor access and penetration of surgery among qualified candidates doesn't just apply to lower BMI people. It's just a tremendous problem overall. And as Phil well knows, others do, among qualified candidates in industrialized nations, fewer than 1% actually undergo metabolic surgery, and fewer than 1% actually use prescription weight loss medications. One of the last things we did in the Diabetes Surgery Summit series of initiatives was to convene a conference with a main theme of coming up with an understanding of the barriers to uptake of metabolic surgery. And we identified many of them, but we published one of these in particular with a position statement that came out last year in Nature Medicine, defining the entrenched and durable level of obesity stigma that pervades our society and includes people in the healthcare system and tends to make people afflicted with obesity self-loathing and feel guilty and feel it's just their fault, so they don't seek care of any kind. And we, in this paper, put together an international call for the end of obesity stigma and means to get there. But it's a very difficult problem. And I think our field has not been very good about getting the word about the excellent evidence-based out to rank and file people. We've not done a very good advertising job yet. So a lot of people just don't know about how effective, safe, and cost-effective metabolic surgery is, neither providers nor patients.
Okay, we have also a comment from Dr. Abdullah. Yes, you can.
Good evening. I'd like to welcome you all, and special welcome to all international guests. I do agree with Professor Adnan that we are facing problem with the overwhelming number of obese patients requiring surgery, and therefore you find the most of the pediatric surgeons are subconsciously preoccupied with obese patients and paying less attention to the metabolic surgery and indication for metabolic surgery. I personally see the best patient who would benefit from bariatric surgery, whether it is indicated to reduce weight or to ameliorate metabolic syndrome, are those who are having a metabolic disease. And I believe we are at the Sasmbs should improve the awareness of indication of metabolic surgery. We are all concerned of diabetes, which I do agree with, but hypertension is prevalent in Saudi Arabia, and the rest of the metabolic syndrome. We have a prevalence of 57% of metabolic syndrome in Saudi Arabia, and I think we should pay attention to this. Thank you all.
Dr. Sultan.
Yeah, I agree with everybody, and just want to add the good thing now that we have a young generation of endocrinologists. I remember last year we organized the first conference about surgery for diabetes, and they were very aggressive in their criteria for metabolic surgery, and they want to go below, even below 30, body mass index of 30. I remember when we started Dr. Osama, 2004 and 3, it was extremely difficult time. So I think with time, it will be much, much easier. We have very clear evidence, 12 to 14 randomized controlled trial now. We have it available with us. And I think it will be the future, inshallah.
Inshallah. Dr. Osama, your final.
Thank you. I think there is one other issue that I would like to mention. First of all, we have been doing class 1 obesity, and I think many of us who've been in this practice for so long, we've seen that it is not only, and in fact, the DSS went ahead and made different levels of recommendation depending on the comorbidities. They did not restrict themselves to diabetes, and that's a blessing. But when we look at the insurance effect, having only being or advocating only a sleeve in Saudi being approved by the insurance provider, that was a problem. And I think Ali Aminian and Weiji Lee and the others have looked at how the reserve or basically the insulin secreted capacity plays a role. Sometimes you would like to do a bypass on a patient who is a low BMI because you believe his insulin secreted capacity is very weak, and a sleeve may not help him. You need a stronger hormonal procedure. And that is when we face problems. And we've been dealing with them in our own way in a private practice. But I think that issue is our future focus, is trying to improve access and trying to make available more procedures for our patients. Thank you.
Thank you. I would like to launch the next pooling system regarding the pre-operative workup, and it's asking about the H. pylori test. So kindly, if you can respond to this poll, and if you are doing it as a routine workup regarding H. pylori test.
الوحيد لازم نتكلم احنا مع اكسبيرينس احنا ما نقدر بس نسوي سليب صح؟ الباقيين ما قاعد يفكرون على النقطه انه في السعوديه ترى في مشكله اغلب الناس بتسوي سليب صحيح ما يسوون مني ما يسوون
احنا مشكلتنا دكتور اسامه اكبر من كده. احنا البي ام اي اللي approved by the insurance, it is not the standard of care even, and this is again with another fight with the insurance company to have it. So another 10 seconds, and I'm ending the poll now to start the discussion about this issue and the preoperative workup, the second lecture, which was the presentation, which was by Dr. Sultan. So I am sharing with you the result. Dr. Sultan, so 43% yes, they are doing, 57% they are telling no. So
yeah,
what is?
I agree with them, and preoperative evaluation should be more than that. And we learn from our past experience that reflux is the most common issue that we are facing now following bariatric surgery. So I think we should do better evaluation, and this should include endoscopy. And I leave it to the gastroenterologist. He will decide whether he's gonna do it, take a biopsy and do clot test or not during the endoscopic finding.
So what do you think about that, Dr. Hanan?
Thank you. Sorry. Regarding doing H. pylori, as you said, we are dictated on doing pre-operative investigation we are dictated by the insurance. Whatever we agree on exactly will be faced by, a strong rejection from the insurance. In our setup in the government hospital, we don't do H. pylori as a routine. But if the patient is symptomatic, we can go even further for upper GI endoscopy. So we're more liberal. But again, as I told you, the insurance will limit this.
What about Dr. Abdullah, your practice and in military hospital as governmental hospital? Do you request it routinely?
Yeah, when we started the bariatric and metabolic pathway, the upper GI endoscopy and hydrobiliary testing was a routine in all patients, and we are still doing it as a matter of fact. I have been asked several times that should we stop routine upper GI endoscopy and be selective. I haven't decided yet, to be honest with you, but we are encountering patients having, abnormal pathologies, and I would say more than 70% of the patients are Helicobacter pylori positive, and that goes with the national study of more than 80 to 85% of the Saudis are Helicobacter pylori positive. So should Helicobacter pylori be eradicated preoperatively, or you treat accordingly? I find it, to be honest with you, very difficult to answer, and I'm still doing it routine. In private, we are facing problem. Most of these investigations are not approved by the insurance companies, and therefore I try to go more selective, and whenever patient got symptomatic, I do an upper GI endoscopy for them, as I follow all my patients in private for 40 years before I decide no further follow-up. Thank you.
Excuse me, Assam?
Yes, Professor Adnan.
Yeah, I agree. مساك الله بالخير, Abdullah. The thing is that in the governmental hospital where the cost is covered by the hospital, you can do anything. The problem is more than 70% of the bariatric surgery is done in the private sector and on insurance coverage. This is not covered by the insurance in any way, even unless it is ordered by other specialties or other disciplines, from surgical or from obesity management teams as a multidisciplinary. It is not covered, it is not approved, and so the patient has to bear the cost of these tests. So preoperative endoscopy, H. pylori test, all other tests are a waste of time for the patient. Well, we have it. We have our guidelines. We have our recommendation. But the thing is that these are still something which is recommendation. It is mandated by the society. It is mandated now by the public health authority. But the things, these are all, as we say, it is an academic issue for the patient and for the users. It is who's going to pay for that. And until now, the insurance or the other coverage post or authority, they are not covering these things. So we hope things will get better in the, and we are as a part of the whole world. And I think the issue is similar in the state or in Europe or other areas. Thank you.
Dr. Osama, تفضل.
We're not seeing this problem, and I'll tell you why. Because if a patient has GI symptoms or we think he has an issue with his stomach, we send them to the gastroenterologist and they can order an H. pylori, and the insurance would not have a problem. They wouldn't have a problem with us surgeons ordering it, but they don't have a problem with the gastroenterologist ordering it and managing the patient. That is not, for us, we don't see that as a problem. But
this is true. This is true. Yes, Osama. Yes, I agree with that. It is true, but it has to go through the gastroenterology as an issue there. Thank you. Yes, that's true.
Okay.
Dr. Osama, can you allow? Yeah, Dr. Osama. But do you do it routine or you do it on demand?
I tend to look at it as this way, and maybe this is strange for many of you. I think many of us carry H. pylori as part of our diet. And if you overtreat patients for H. pylori, you're going to end up with resistant H. pylori unnecessarily. So I only treat patients who are symptomatic, and then I would do the necessary testing appropriately. I think H. pylori tends to complicate an ulcer when it is there, and you need to treat it if there was an ulcer. But if there's a normal stomach, why would you eradicate it? And he'll have it the next day after he eats another meal. That's how I think.
Dr. Abdulrahman.
Assalamu alaikum.
Alaikum assalam.
Hi everybody. I think if you ask the gastroenterologist, it is the H. pylori is contraindication or not, they will tell you it is not contraindication if the patient have no symptom, they have patient no symptoms. So I think as long as there is no symptoms, presence of the H. pylori probably is not contraindication. It's not, it doesn't carry any medically significant. So I think, and most of our patients here in Saudi Arabia, they have H. pylori. So once in the beginning of our practice, we do H. pylori, we take concern about the H. pylori, but now we found this is insignificant as a recommendation of the gastroenterologist. If asymptomatic is not any more contraindication to proceed with the surgery. Thank you.
Okay. Okay, I would like to move on to Dr. Michel Gagnier and regard the re-sleeve. I would like to ask the panelists and all our eminent surgeon and contribution, who is doing re-sleeve in his practice and practicing re-sleeve for cases. Can you raise your hands, please? 1, 2, 3, 4, 5, 6.
I am against re-sleeve. I was raising my hand to comment.
To comment. Okay.
To comment. So okay. I am against re-sleeve. I have bad experience. I had three, not big experience. I mean, 3 cases. Two succeeded. One leaked. And treating that leak really made me really frustrated, and I really stopped because the patient needed, alhamdulillah, he did not pass away. I managed him myself. It took me more than 5 operations and 2 times stenting. Eventually, we could do it, but not even bypass. We did it primarily, but at the stages. So after that, I just quit doing it. No re-sleeve. I do re-sleeve for big pouch, but also I do bypass at the same time. And there is also a scientific basis for weight loss after re-sleeving. I mean, if they fail one restrictive operation, why would you do another operation? The patient is pushing for it. They are addicted to sleep. They think it is more like natural thing. But actually, if we focus at the target, which is weight loss, and doing it in a safe way, re-sleeve would not address this at safety issue or at when we focus in weight loss. So I'm right now I'm totally against it.
Okay, Dr. Wael.
If you may allow me, I would like to contribute and to comment. Can you hear me?
Yes, we can hear you. Yes.
Yes. Okay. I think the term re-sleeve is a little bit broad. I think we need to define why do we have a failed sleeve. If a failed sleeve because of a poor performance from the beginning, where there is a large sleeve, not a tight sleeve, with a large either a prepyloric pouch or a remnant fundus, I think the role of re-sleeving could be there, because I wouldn't consider the patient had a proper sleeve from the beginning. If the patient failed the sleeve after losing weight because of metabolic pathophysiology, then I wouldn't recommend the re-sleeving. I would recommend a more of malabsorptive procedure. So I really need to be careful when am I going to consider re-sleeving or not. Regarding the previous question about the H. pylori, I think that the H. pylori wasn't, and it is not the main issue. I think the most common problem that we face from the upper GI pathology is actually the GERD, not the H. pylori positive. So I wouldn't think that routine H. pylori testing is indicated. And even if the H. pylori is positive, I think there would be no contraindication to proceed with the surgery. And not everybody with the H. pylori positive needs to be treated or eradicated.
Thank you, Dr. White.
Especially if he's not high risk. But our problem, our GERD patients, should we endoscopy to all, especially that in our community in Saudi Arabia, many patients, they underestimate the upper GI symptoms. So even when you ask them in the history in details, they don't really elaborate in saying that they have GERD symptoms or heartburn or other symptoms. So you face a lot of probably with GERD patients and hiatus hernia intraoperatively. Thank you.
Thank you. Dr. Ali Al-Muntashiri.
Yes, Dr. Sam.
تفضل. You raise your hand.
Raise your hand and
اللي هو re-sleeve انك انت do you do your re-sleeve?
Yeah, actually yes. I do practice re-sleeve. It's not the first option always in my revisions. I always explain to a patient protocols. There is contraindication if the patient have any signs of GERD endoscopically, because all revision I do sleeve, I do barium, and I do gastroscopy. This is routine, even in private. If the patient going for revision, he should have gastroscopy and barium. If any signs of reflux, we don't do sleeve. If no signs of reflux, then I consent the patient both on sleeve and on bypass. I tell them intraoperative, I have to decide. Yeah, intraoperative decision, because sometimes you see in the barium that there is big fundus or dilated pouch, then you go in, you are not happy with the amount you're gonna cut. So I always take both consent, re-sleeve plus minus gastric bypass, and I tell them I need one of the member of family in charge of this. So when in the middle of the operation, I'll go out to discuss the option of gastric bypass. Because I believe the same like what she said, Dr. Hanan, that I'm treating restrictive for the restrictive procedure. So even if, as Dr. Ghatan said, it is not probably done from the beginning, still you're choosing another polyp. Yeah, I mean, you're losing another polyp. You will put the patient again to the re-sleeve. If failed what? You will take him third time for bypass. But I think we have to be very careful in choosing re-sleeve for the patient. I'm practicing it based on the patient request. I got the patient said, if you couldn't do a sleeve or even you are not happy, intraoperative, don't do bypass. Even she did not sign on the consent for bypass. So some patients, they ask for it for re-sleeve and they want to do re-sleeve. That's where we're stuck. Unless if it is contraindicated, I don't take them at all.
Okay. I would like to congratulate Dr. Osama regarding his participation. And okay, so I would like to put the selection criteria regarding the pool for the ERAS and to launch this pool again regarding do you practice and implement ERAS in your institution. Until everybody will respond to that, Dr. Haider Shurafa, you can speak up, please.
مساء الخير, good evening for everybody.
Thank
you for all organizing committee and my colleague with this very rich talk and very rich knowledge we have learned tonight. I just want to say something about re-sleeve. In my practice, I did 9 sleeves. All of these 9 were either to weight regains or inadequate weight loss. And if we look in the data, we see that these re-sleeve cases has needed it because they originally were super morbid obese with a very high weight while they did the primary sleeve. And in those cases, probably what my explanation for that was the difficulty in doing the sleeve in super morbid obese ended with inadequate creation of pouch. That these 9 cases, this is what I learned from them. But again, I think re-sleeve, as Dr. Michel Gagné have already presented, it's still in the market and they do it, but they always concentrate on the selection criteria. So I don't think we can take it as a broad and very public terminology. So patient post sleeve, he can go for re-sleeve. But probably we can say every patient asks for re-sleeve, he should be evaluated for his primary sleeve. So in proper sentences, those patients need evaluation to exclude or to prove the possibility of re-sleeve. And again, we should mention re-sleeve is more demanding operation and probably need a lot of security and preventive measures during the procedure. I would like again to thank everybody and thank you for giving me the chance.
Thank you, Dr. Rashid. So I am sharing with you the pool for regard to practicing the IRAPs in your institution, and we found that 52% is positive that they are practicing. So I think this is a good percentage that's make Dr. Osama happy for at least everybody start to preserve more with the cost and cost effectiveness, especially regard in practice and in private practice, unless if the people who is still struggling to convince their stockholders so that they can do the IRAPs effectively. Dr. Abdullah, تفضل.
Yeah, thank you very much. I'm just getting back to shed the light on the re-sleeve. I do re-sleeve and I see those patients are doing very well. But before that, honestly, you have to look into those patients who regained weight. Why do they regain weight? Is it a patient factor or a procedure factor? If it is a patient factor, you have to know that whether you re-sleeve them or you do bypass, whatever you do, you're not going to gain anything with this. You are trying to get an ideal procedure, but on non-ideal patient. So this is the problem. Most of the outcomes sometimes we get an ideal outcome, and the problem is not the procedure. The problem is an ideal patient. So in those patients, if you think there is a patient factor, then they have to be educated. Once they are educated, they know that they did a mistake with their dietary habit, with the first procedure, then it's your call to look into the pouch. If they have a reason to explain the weight regain, then yes, you would expect if you re-sleeve them, they would benefit. But if they are not having, honestly, a wide pouch, then it's pointless to re-sleeve them. Same thing for gastroesophageal reflux disease. If they have gastroesophageal reflux disease, if there is something that can explain the gastroesophageal reflux disease and you think you can correct it surgically, then go ahead. And if not, then you better convert it to a gastric bypass or any other procedure as indicated. Thank you.
عصام.
تفضل دكتور سلطان.
أسامة ما هو فيه يجاوب عن الإراز. لكن again for I think the only indication, in my opinion, and maybe most of the people agree with that, for re-sleeving, rarely I do it, in case of insufficient weight loss to start with. When you have insufficient weight loss, nobody happy about the initial weight loss, and then you do pre-op evaluation and you will see a big pouch, and it's very clear that the procedure was not done right from the beginning, then I would probably consider a re-sleeve. But when I go back for any sleeve procedure, I would like rather add malabsorptive components. And this is not going to be enough. We need to encourage the patients for more commitment, educate the patient, and we see it even with gastric bypass. We have recurrence now of weight. We have this problem, but re-sleeve in the absence of history of a patient with excellent initial result of sleeve, and they maintain it for 2 or 3 years, and coming back after 5 years with weight regain, I don't think re-sleeve in this case is good option.
You know, my biggest concern, if you allow me, Dr. Sam.
تفضل.
My biggest concern with our population, they are carbohydrate eaters. And in those patients who are not educated, if you do them a malabsorptive procedure, then you are calling for a problem. Because with malabsorptive procedure, don't expect them to reduce the absorption of carbohydrate. You are working on the absorption of fat and protein. And I had revised patient to a bypass, then it was a nightmare on those patients. I had to go back and revise their anatomy. One of them ended up with renal failure, as a matter of fact. Poor compliance, they don't comply with their supplement, and they don't comply with their diet. They keep eating carbohydrate, and this is the biggest problem. So in those patients, if they are really poor compliance, then it might be wiser to keep them with the sleep, because it is more physiological than the malabsorptive. But if you give a luxurious car to a bad driver, don't expect to make him better. And this is my biggest concern with those patients. Thank you.
So this is bring us to the next question regarding the number of revision cases that we are doing in Saudi Arabia. Are we with the same trend worldwide, which was presented by Dr. Michel, that we are having more of revision cases than just only to do, even just only as a re-sleeve, doing any other procedure and making more revision cases? Dr. Osama.
I'm sorry, I didn't listen to your question, but let me tell you, I'm showing you on the back how I convince patients what happened to them. Sometimes you get a patient who did not have a sleep, and I agree, but they are a rarity now. Previously, we did have a lot of re-sleeves because they were not done well, but nowadays we don't see that as of. So I agree with Dr. Sultan Tamir that we rarely now do a re-sleeve on a patient.
But sorry, Dr. Osama, why you call it re-sleeve? If it is not done primarily, it is gastrectomy, so it is the primary sleeve.